right, good morning, Dr. Richards.
Good morning.
We're here a little sad after the last week's loss from the Eagles, but we'll try to soldier on. Today we're going to continue our discussion of pain, a very important topic. We'll go forward there, try to cover everything that we could cover here, but obviously this is an open conversation that we'll continue as we learn more.
Yeah, absolutely. So, I know last time we started to get into talking about pain onset identification, kind of really figuring out when that pain and where it's coming on. And you have 11 categories that you go through when you're talking about that. I was wondering if, can you go into depth a little bit more about what we were hitting on last time regarding onset identification?
Yeah, one thing I wanted to touch more on is how we use these different, assessments to basically give us broad categories to help us know where to treat. So you can think of it as like a funneling system where, all right, like in your head, you have a step-by-step system of saying, like, I want to find where this individual's onset of pain comes on. And then once we figure that out, then we have to have some categories that help us decide how to treat. So, for instance, we talked about graded motor imagery, which is basically a broad category of pre-movement assessment, right? So if somebody is having pain, even just thinking about movement or contemplating different proprioceptive tasks, well, you know that they're going to probably be categorized as a pretty irritable presentation at that point. So we have to be really careful there. And the idea of training through movement, but is not really on the card. So we can kind of put that early on into this category that we're looking at something that's really sensitive to movement or even pre-movement. So we'll call that like an irritable category, right? And that's just going to be a very different type of treatment plan. And it's going to be something that we're looking at the biopsychosocial situation way more than we're looking at movement at that point. There's going to be a lot of education involved. There might even be a lot of apps and technology involved where we're trying to get people more interested in the current science of pain, because that tends to be important. But anything we do from a movement standpoint is going to be absolutely very gradual. And the most important thing there is going to be that the individual that we're working with feels very safe with any progression we're making. So it's almost like we need to get permission, which we kind of do anyway with any treatment, but there's sort of this informed consent that we really need to be specific about that with people that are in this sensitive, irritable category. So we can look at some of the earlier assessments here in this continuum of saying that might put people into this sensitization or irritable category. So even with graded pressure application, if the Maitland method of manual therapy, really they break down how you put your hands on people into different grades, so grade 1 through grade 5. But early on the grades of pressure application, they look at pre-resistance, so tissue resistance, where you're actually feeling that you can actually put your hands deep enough into the tissue where there's some resistance, versus pre-resistance, which would be like you're just sort of laying your hands on someone and there's already pain. That they try to make a distinction there, which would, if you're not able to get into resistance before the onset of pain, then you might be thinking, okay, I have to again categorize this person into more of an irritable presentation, which we have to be more careful, and we have to think of it in the way that I just described for graded motor imagery. So again, even within these categories of assessment, we have ways to progress or regress, and then even funnel out into other categories. And the same thing could be true with active motion, passive motion. So if active motion, if you're telling someone to lift an arm, and just even the thought of lifting an arm or just the initial onset of it, you can see a ton of guarding. You can see a lot of just non-willingness to want to move, right? A lot of apprehension in just being asked to move. Then we're not going to force that. We're going to kind of back off, but we get a lot of information off of that. It maybe doesn't give us the best assessment of the exact point when pain comes on, but it shows us the thought process of the individual at that point. So if, again, that the movement is a lot more a lot easier for the client, and they can move pretty much through the full range of motion, but they get to say an end range of that motion and it becomes painful. Well, now we might start to categorize that as like, yeah, they're pretty good except for at the very end range. Maybe we just need to improve mobility. So we can kind of categorize that as a mobility based presentation, or if there's some pain just in the mid range of the movement, that can give us a different information. So I like to think of things as like mobility based versus stability based, which doesn't necessarily say that, oh, okay, one needs stretching and one needs stability. It just means that we're going to look at this a little bit differently in our treatment. So if there's like a mid-range pain, a lot of times we're going to have to give a cue for stability, a lot of times more centrally in the proximal region, and try to reposition something to see if it actually takes that symptom away in that mid-range. So there's an expectation that you might be able to adjust something in the moment to take that mid-range pain away or decrease it. Where with end-range pain, sometimes the expectation is that it's a more stable pain, that you may not be able to change it with positioning in that moment, but you may have to change it. You may expect that you have to go into that a little bit and have the tissue change over time. So it's not always that way, but that could be something you're starting to think about as you're seeing where the onset of pain is with active motion, passive motion, and even pressure application again, because if you get it deep enough into the resistance of pressure application, so say you're putting pressure down into somebody's tissue, trying to say mobilize a joint, and they don't tell you that there's any onset of pain until you can't press down anymore, then it seems like a healthier situation than if they're complaining of pain with just laying your hands on them. So all of that is stuff that can be graded and looked at as, all right, categorizing what this person is ready for. All right, so the same thing could be true for graded isometric resistance, right? Like you can have a 0 to 10 scale in your head. If I'm giving someone 1 out of 10 resistance versus 10 out of 10 resistance, right, there's a different categorization process. Again, if you just put your hand on someone, and I've seen this a bunch of times where I'm trying to just measure a little bit of graded resistance, and before I even touch someone's like, be careful, right? And so, you get a sense right there. It's like, okay, I'm absolutely going to be careful. And I might not even go through the process of testing the resistance at that point, because I probably won't get a true assessment of their strength because there's so much apprehension there. But I might just say, okay, like I have to treat this person a little bit differently. Maybe I'm a little bit more hands off at first, or I'm certainly not going to use a lot of force in my resistance testing. All right. And then the other categories where we'll get into this deeper in other podcasts, but this is more within the movement continuum of, we talked about positions, we talked about transitions, we have supported positions, we have supported transitions, and we have a progression of how we take support away till we finally get to unsupported positions and transitions, and then we eventually add resistance to both of those. So that's pretty straightforward there. It's just thinking about, what's going from support to unsupport, or to a lack of support. It would be something as simple and could be as graded as, okay, I'm holding on, if I'm trying to balance on one leg, I'm holding on to a pole with 2 hands. I go from 2 hands to 1 hand. And even with 1 hand, I go from 5 fingers to 4 fingers to 3 fingers to 2. Rarely in the clinic does it have to be that specific, but it can be if somebody really needs that type of control. And I think it's important for clients that are really irritable to see that they're in control of a very specific process, to say, here's what you can do to make this as easy as it can be. A game of inches, but you can even say it could be a game of millimeters for you if you want it to be, right? So, trying to get people more objective in the way they look at progressions and regressions could be really helpful when there's a lot of apprehension. So that's the idea of that continuum for me. It doesn't really need to be used like 1 through 11. Like, I don't think I use all 11 very often, but just having that in my head and then being able to explain that to people that are really apprehensive to movement, to say, yeah, we can go less than this. Believe me, there's a lot less we can do. And then there's always more we can do. All right. So this is a process that we're in. You're in control of it as much as I am. I'm just going to try to help you out through this process, but to sort of let them see both sides of it can be really helpful to give them some self-efficacy to move forward.
I'm curious, when, pain obviously kind of tells us a lot about what's going on, how irritable someone is, where the pain is, it gives us a lot of answers. Um, but are there any times where when someone's experiencing pain for you that, you'll kind of say it's okay to go into it a little bit or go through it a little bit or work through it a little bit? And when would those times be for you versus when would you more so sort of stay away from it as a whole?
Yeah, that's a good question, especially as a follow-up to what I was saying there, because if say you get into those more end range states where somebody's pain comes on, you can use a repeated motion assessment sometimes to see the more pressure I go into that area, does it make the symptom worse? Does it make it better? Right? What's the aftermath of either the movement assessment or the pressure assessment? If you see that the symptom provocation is very stable, right? So it comes on as soon as you take the movement or the pressure away, it goes away, and it happens pretty consistently that way. A lot of times that'll give you some information that, yeah, we can go into that a little bit because it's giving you pretty consistent feedback that it's going to go away, and the client can see that too, so they get more confident that it's safe, right? Versus if you're in that more irritable state where you're not even going into the resistance of the tissue with pressure and symptoms are coming on, you're definitely not going to want to go into that symptom much, and you have to be careful even on the initial assessment going into it at all, right? So that's where the subjective discussion with the patient may give you a lot of information of like, do I even want to try to assess into pain provocation today? Because if their language is very much so that they're apprehensive, experience has shown me that, yeah, it's helpful to get that direct onset, but that direct onset is not going to be very accurate anyway if there's a lot of apprehension around things. So with somebody who the subjective even tells you that they're irritable, I might not even mess with any of this stuff too much, or that could be a point where graded motor imagery comes into play at first, where it's like, okay, let's do some discussion. Let's get somebody moving in a way that they feel safe, distant from where they're saying that their pain is, and then do a lot of education and some pre-movement stuff that's more direct to the location of injury. But going into the symptoms, yeah, like if it's more like that end range type of pain, I think if you're familiar with like the McKenzie approach to categorization, they have their derangement, their dysfunction. Derangement would be more of what the mid-range pain that we were talking about, or where there could be this abrupt change, like we're able to make a quick change to the symptom just by moving in the opposite direction of what's bringing the symptom on. That's a very crude way of talking about that definition, but then dysfunction is you do have to go into the symptom if you want to make it better. And that to me is almost just like more like the tissue is short, right? You're trying to get to you have to get to the end range to make change to the tissue. And when you get to that end range, that's when the pain comes on. So it's a very stable presentation, but you have to have an assessment of not just during the moment of when the pain comes on, but asking, how does that feel when we're done with it? When we take the provocation away, does it go away? Does it go back to baseline pretty quickly? And if it does, you start to get an idea that, all right, that's pretty stable. I think we have to go into it. And you also, again, have to get the permission from the client. Does that make sense to you? Does that feel safe to you to go into that?
I think subjective tells a lot in that scenario too, because it's like
Absolutely.
the onset of pain is probably, or the onset of injury or how this all started for them is probably going to be a little bit different, where derangement, I feel like, or kind of that sort of mid-range volatile pain sometimes can just be a pretty quick and abrupt onset. Sometimes after a traumatic, injury, or sometimes not, but versus that sort of end range tissue dysfunction we would be thinking of would more so be along the lines of probably a gradual onset over time,
Right.
because that tissue did shorten. So, that sort of, I guess, circles back to what you were talking about, just with the subjective is going to dictate a lot about what you're going to be able to do with a person, especially in that first evaluation.
Yeah, 100%. And the acute versus chronic nature of the symptom, yeah, it gives you a lot of information. One of the things I see frequently, and I probably see it more frequently now that I have so many people that I'm seeing through for years, but then they might have like an initial onset of a symptom that just comes on randomly, but I get to see or hear about the symptom in the first day or two, right? Is that it's more of a transition to initiating movement that brings the symptom on, and it's very much like that kind of mid-range type of thing where if you actually stretch to the end range, it feels better, because the symptom early on is really looking for stability, right? It's looking, and so it's in this protection mode. So if you've been sitting for a while, okay, well, there's some protection and stability from being in the chair that you're sitting in or the bed that you're lying in. But then you go and make that initial movement to go from sitting to standing or from lying to standing. And that's when there's a ton of pain. So you tend to hear, okay, rolling in bed is killer. Pulling the sheets over could be killer, just because it's going from non-movement to movement. So I see that a lot early on. To me, that's a stability presentation. But if it's acute, it's also probably an inflammatory process. It's an immune process early on. So we have to, medicine might be the best thing for that, just because of the acute nature of it. But if it's been going on and it's the same type of symptom for months or years, then I'm sure medicine's probably already been part of that equation. And we then have to teach a different strategy from a movement perspective. So, your prioritization, it's like what we do as therapists isn't necessarily going to change in the acute versus chronic standpoint. Like what we're going to still educate probably on a lot of the same strategies, but our expectation for what's going to be most useful will certainly change if it's acute versus chronic. So I'm a big fan of pushing people towards medicine if they have an acute, really bad acute symptom that's within the first 24 to 48 hours. It's like it makes a lot of sense to me. I've seen it be, as much as I want to try to be the thing that helps people, it's a cortisone injection that can be helpful, or just even take some oral steroids. And I know the downstream effects of chronic steroid use is not optimal, but acute steroids versus chronic steroids is completely different, right? Yeah. So acute anti-inflammatories versus chronic anti-inflammatory use, completely different. So being the person that can educate your client on the difference there, because what I get a lot now is people are so in tune, or they Google something about the negative effects of medicine that they're afraid to take medicine. So, medicine is great. We just have to understand, like what's the difference between mindlessly taking medicine every day and not trying to do anything else to change yourself versus being in an acute episode of pain. The best thing you can do is take medicine in that point to get you out of that pain so you can restore function as quick as possible. But it's, so just separating out not just the acute versus chronic idea of pain, but the acute versus a chronic idea of treatment, right? And medicine use.
Yeah, I think that's a really good point just on kind of scope of practice overall. But I think it's cool, like with, the scenario you're in where you've had some of these clients for, 8 years or longer. It's like you're in a unique position to actually see people so acutely after an injury as a physical therapist. Whereas I think in, general outpatient, or I would say mostly general outpatient, it's like you're not seeing people in those first 24 to 48 hours normally. It takes a few more days for someone to want to actually like get a script or schedule an appointment to come in, waiting around, versus when you have people that are already coming in to train and then something comes up. You have that kind of goes back to our first podcast on being a movement professional and bridging the gap between rehab and fitness. Just you have all these tools in the toolbox to actually be able to address things in a pretty unique environment, which I think is pretty cool and powerful for your clients.
Yeah, it's been interesting to see how things have evolved, because it certainly wasn't the expectation, or I didn't know how that would go. But that is the cool part of seeing people. Like ideally, I think in your head you're like, well, if I'm just training them, I'll never have to deal with pain, and that's it's just not the reality of things. What you start to see is, people get episodes of pain on and off for a variety of different reasons. It's hopefully it's not within the session that you're creating the pain, and rarely I would say that's the case, but I mean, even that happens just because you're assessing people's limits oftentimes in fitness. You're seeing like, you know, what they're ready for. And it's often hard to predict, but I know being into fitness myself, you experience it too. It's like we're pushing our own limits, and sometimes we tweak something, right? And being in that acute state of pain, it happens. And I think it is part of something that's almost necessary to continue to progress physically. But it's certainly by not doing, you know, by not being physically fit, you're not going to prevent pain, right? So,
Yeah.
you know what I mean? Like we have to appreciate that, you know, it's a risk management process. The idea of full-blown prevention is not possible. So just getting to experience that and doing the best for your clients, but also knowing that you're going to have to see some acute episodes of pain and be able to understand like the best treatment there, right? And it sucks, you know, when you're in acute pain, it's terrible. Like one of the things I see is the more fear around it, like the more you think something's wrong, something just broke, and I need to figure this out right away. Like there's this urgency that happens because the pain is so intense early on in acute state. That actually can be misleading because the pain is going to be the worst in the first like 24 to 48 hours, but it usually doesn't mean that you have to do anything about it except let it go, right? Like you like take some medicine maybe to get it over with quicker, but like it'll kind of work its way out a lot of times, but it's not that something was damaged and needs to be fixed. A lot of times it's just that it's acute and it hurts the most because of the timetable, not because of what actually happened, right? And the more you appreciate that, then the more you're like, okay, I don't have to be fearful of this. I just have to, you know, appreciate that it's going to suck a little bit, but I'll actually be better if I work around it, because there's nothing I'm healing in a way, right? It's just like I'm letting the process unfold, and I just have to listen to my body. But oftentimes there's this like freezing mechanism where, okay, the pain is so strong that that there's a lot of times my clients will be pleading with me, but like, you don't understand how bad this is. And I'm like, I'm not, I do, or I don't need to understand how bad it is. You know what I mean? It's like, it's not, I'm just trying to help you, you know, like appreciate that it's going to be the worst early on, right? And that's a hard thing to understand because it is so bad early on, but it doesn't tell you that it's more serious necessarily.
Yeah, definitely. And it's interesting too, because it's that mindset early on is, I think that's the only thing that's really been found to be a predictor of, at least for low back pain, like chronicity and low back pain is, you know, how do you actually relate and think about your pain? How fearful are you of it? And that plays such a big role. So that's where that education piece combined with medicine and continuing to move in some way in that acute stage plays such an important role.
Yeah. And I'll even drop a little plug for mindfulness in there, just because
definitely,
you know, mindfulness is to me, and it's been a really important part of my life, but it's not, it has potential to be whatever you want it to be. But I look at it as just really training of the way that you look at things, right? It's a training of the mind, it's a training of the emotions, but it's a slowing down so you can actually, I think, see things more clearly. So pain is a really good example of that. There is the physical sensation of pain, and then there is the story around it, right? And to be able to separate that out pretty consistently and make pain, okay, this is what it physically feels like, and it's uncomfortable. And then this is what I'm telling myself might be wrong, right? And there's no judgment there, right? Like we all do that. We, as therapists, we probably do that more than anybody because we have a very specific way that we can assess a lot of pains. Like that's what we went to school for. That's what we see clients for me. It's like 16 years now. So it's really easy if I'm sitting down and I'm trying to be mindful of a pain that I can go right into diagnostic mode. You know, I'm assessing, you know, what's wrong here, what structure broke, or something like that. But the mindfulness game is to say, like, this is what it feels like physically. That's it, right? Try to separate those two out, right? And when the time is actually necessary to diagnosis, be able to do that, right? But oftentimes it makes the symptoms worse. It makes the process worse if we make the pain and the story behind the pain be the same. So we have to be able to separate that out. So I think that's a really helpful thing, but it's hard to, unless you have a practice of mindfulness, it's hard to be able to do that.
Yeah, definitely. And it's funny too, because it's like we know as therapists that like the negative consequences of overdiagnosing, and that, not every hurt equals harm. But
Yeah.
like when it comes to ourselves, at least I've fallen in the trap of, when that initial acute injury happens, you're like, all right, what's wrong? And
Right.
then you kind of have to, excuse me, bring yourself back to that mindfulness piece and understand that pain and what's actually going on physiologically in the body aren't necessarily, and really aren't the same story a lot of the time.
Absolutely. And I think the other thing that mindfulness helps with is you start to realize your own biases too around pain, right? Because we all have it. Like it's a cultural phenomenon a lot of times with pain. You start having opinions from your friends. A lot of times it's, in our case, a lot of our friends are people that are in the industry, so it might be more useful, but people that are getting information from their friends that aren't in the industry that just have happened to have what sounds like a similar pain, that's very unhelpful. But that's what goes into what you think pain is. And I think it's really, if you have a mindfulness practice, you could start to see your own biases and then let them go. So for instance, like there's certainly a bias within our field that trying to not take medicine is a good thing, right? Like I certainly noticed that. But if I was really being mindful of the situation, it was like, okay, I'm in acute pain here. I don't have to think anything's wrong, but it makes sense for me to take Advil right now, right? And I could separate that out from the feeling that maybe in fitness, like I'm losing a battle there if I have to take medicine because I'm not able to figure out this outside of medicine, right? So you could even start to notice your own biases, your own judgments, just because of where you're coming from, and vice versa. It'd be true. Is like there's people that just, they don't want to have to go through a process, so they're like team medicine.
Yeah,
and they want that to be the way because that's the easiest route, right? But instead of just having to pick a team, if you're mindful, you can start to see like what's the most useful path, and a lot of times the most useful path is a collaborative path of a lot of different approaches.
Definitely. 100%. That kind of, I guess, ties into a little bit something I think we both wanted to touch on was scope of practice regarding pain. And I was wondering if you could talk a little bit about that.
Well, I think when I was in school, and I want to get your take on this too, because it's been different generations of schooling for the same profession, but there was a lot of discussion about scope of practice and really making it important that we were distinguished as physical therapists from other professionals. And I think there's definitely something to say about that, but if you get too serious about that, then what ends up happening is I think different professionals really start to have a little bit of an ego compared to others, and then there's this sort of like comparison and competition instead of collaboration. But I think when it comes to pain, you just gotta know what you don't know and respect that, and try to talk to other professionals that like that's more part of their education. That's part of what they're allowed to work with. But I think that if say you are in a profession that you're really not allowed to treat pain, that doesn't mean that you shouldn't learn about it, right? So if you're a strength and conditioning professional and you don't have your physical therapy degree, you don't have a some type of degree that you're in healthcare, it's still really important for you to know that like you're going to meet people that have a pain history. So learn about pain, but don't try to be the one to change it, is what I would say. When you're in that scope, that's not what you went to school for, but really like know a lot about it, because it'll help you from a collaboration standpoint. It'll make you be able to talk to the people that you want to refer out to in a more intelligent way. And you don't want to say like wash your hands of that person. You want to know as much as you can, because that helps you know what you can do and what you can't do, or what you should do and what you shouldn't do. So education shouldn't stop based on your scope of practice, but you do have to know what you're legally allowed to do and what you're not allowed to do.
Yeah, we were honestly, it's funny. It's like however many years later, but taught kind of a similar thing, it sounds like, in terms of, we're physical therapists, we deal with pain, this is what we do. Other professions don't do that, and that's kind of what distinguishes us as a profession. With stress on interprofessional or interdisciplinary collaboration, but really that was more so discussed within the healthcare framework,
Right.
not as much so like looking at training, fitness, strength coach, whatever it is, and then in that relation to pain. Because I think, it's on paper you can say it's black and white, like, not you, I'm just saying people can say it's
Sure.
black and white, where they're not supposed to deal with pain. But like you said, the more educated you are about it, as a strength coach or a personal trainer, if you don't have a degree in healthcare or in relating to pain, the better you're going to be able to actually work with other professionals, and the better you're going to be able to serve your clients, where you'll better understand what movements, what things you can still safely do with them, what things to stay away from. And, if you're in the strength coach setting, especially in the collegiate setting, a lot of times you probably are going to be dealing with pain a lot, because players are going to be coming, either kind of nicked up or like full on injured after a game or after a practice, in addition to probably a lot of times helping to take on the latter part of a rehab for something like an Achilles or an ACL, where you're actually kind of training them in the weight room. But I think it's on paper, it's like the lines can be black and white, but in reality, it's just, there's a lot more gray there. And I think you said it perfectly, like, just because it's not required for your profession doesn't mean you stop there and you're not educated on it. Because in reality, just lacking that knowledge is probably self-limiting.
Yeah, absolutely. And I think like what you're alluding to there is like the, trainers, strength and conditioning professionals, like if you have a relationship with someone where you're seeing them more frequently, you may become like a first responder in a way, more so than the therapist who doesn't see someone until they've been sent there by a physician after several weeks or months of complaining of a symptom. So, having that awareness of, okay, like this is an acute symptom. This is something that I need to pass on right away, or it's just something that can easily be worked around, or that you have someone that you trust in your network that you can just call or text really quick and ask a question about. Like, I think that's really important, because you'll be way more likely, if you're a personal trainer, to see the initial onset of a symptom than a therapist will. And I think that you look at someone like athletic trainers, like a profession like that, and that they're absolutely, like, their education on how to do things in emergency situations is so much better than ours as physical therapists, right?
Yeah.
Unless, that was somehow the niche that, that you're working in, and you've taken that specific extra education, but it's certainly not within the formal education. So, those would be the people that to me would be more expert on dealing with really acute, like red flag type things. And you saw that with Damar Hamlin. Look at the heroes in that situation, where a lot of times the athletic trainers, and I think even in some cases the assistant athletic trainers, right? So it's not about how many years you went to school, but like there's just certain people that, because of the scope in which they're working on, they become the experts. And I think we have to appreciate that, because a lot of times from the outside looking in, people are just asking the question of like, what letters do you have behind your name? How many years do you go to school? Can we put doctor before your name now? And stuff like that. And it's useful, but it kind of muddies the waters too in appreciating like what people are actually really good at and what aren't, right? I think in fitness, it's tricky, because like you don't need necessarily any education to get into the field. And sometimes like you find, just with experience, you get great strength and conditioning professionals that have just been in it for a while. So credentialing, it matters, but don't be limited to that, right? Like you'll learn a lot from people just by listening, instead of trying to prejudge them based on the credentials. So yeah, I think with pain though, I think I talked about this before, where one of the things that being a therapist allows me to do when I'm working with people as a trainer is if I hear pain, if there's a pain discussion, I've been there before. It's a feeling of saying like, okay, I'm comfortable with this discussion, where I find that if you don't have that education, then a lot of times there's this sense of like, all right, hands off. Like I don't want to deal with this at all. Like I'm
Yeah.
passing people along, and it's better to do that than hurt someone. But I think the more you know about pain, even if it's not within your scope of practice to treat it, you'll have more comfort in knowing what to do to not make it worse and work around it, even if that's not your scope to treat it.
Yeah, absolutely. Fully agree.
But I think that ties into the idea of red flags versus yellow flags too, because this to me is an interesting concept, and yellow flags is a more new concept. So I'll let you talk about that a little bit more. But red flags was something that was always like a really big part of, that's like the first thing you learn about pain, because it's the most serious, and it's rare that you're going to see the red flag conditions. But if you do and you miss them, someone might die, right? So it's sinister, and it's really just about like, it's outside of your control. Then there's nothing you can do to help except get people to the people that can help. So but knowing these different conditions or these different symptoms, I think everybody should be educated on that, even the general population of non-healthcare professionals, as much as possible, is just knowing what to look for if somebody's got some type of spinal cord issue, some type of neoplastic or cancerous type issue, vertebral artery insufficiency. That's stuff that the evidence isn't great on some of the tests we have, but just if knowing that that's a thing, and knowing that like, okay, this doesn't seem right, let me have somebody get some assessment looking inside the body. Like we need to have an idea of these things, infections, like stuff like that. So I think that certainly something that's a big part of our scope of practice, but that I think that should be a part of the scope of practice for strength and conditioning professionals as well, because again, they'll see people early on more than we will.
Yeah, absolutely. And the yellow flags are really more so the kind of psychosocial aspect of care. Sort of, you can break these down in different categories, but like some of the most common ones we might see are people's beliefs that activity makes their pain worse, their confidence in actually returning to their prior level of function, or prior level of not actually having pain, their belief that something is seriously wrong or that it's not. And that's kind of what I was talking about a little bit earlier with the things that predict chronic pain. It's really some of those beliefs that put people more at risk at actually having those initial symptoms stick around. And we know too, it's like the tissue healing process at some point is going to actually happen, where if there is an initial injury, someone's going to heal. But if they're having pain years down the road, then maybe that tells us that, well, the actual tissue healed, and it's these factors that are more so driving the pain at this point than any physical injury or sensation necessarily. So it really has to do with the fears and beliefs surrounding your injury, movement, your prognosis, and your confidence that you're going to get back to doing the things you love to do.
Yeah. And linking that back to scope of practice, where it's like yellow flags are a really important thing for someone that's not supposed to treat pain, but to kind of prevent pain from getting worse. They should really understand, because one of the things I see or I get as a report from clients that are coming in that have seen maybe personal trainers that they didn't have a great experience with is the trainer didn't seem to have a sense of these type of yellow flags. and understanding that they had in their head a sense of like, this is what's best for them objectively. They're coming in with a goal of, say weight loss, wanting to build strength, wanting to build bone density. And there's this sense of, okay, this is what I do. This is the protocol for building those attributes. but miss the idea that, okay, there's a lot of biopsychosocial factors that will make them more irritable to movement. So having that sense of being able to know that, you could say, okay, like I'm eventually going to want to have a program that looks like that protocol to build bone density, to build strength, whatever the goal is, to burn fat. But I might have to be really, really gradual with it, and I have to build trust. And I think that's where, you know, an experienced professional just working with people will start to get that. But like being able to really hear that early on and just be loaded with that education to say, all right, if you hear some of these things, you got to slow down. And the most important thing is not the movement you're getting someone to do at that time. It's to get them to feel safe, right? So that's just as important, if not more so important, for the people that aren't treating the pain, so that they don't make the pain worse, or they don't bring a past medical history into a current history of pain.
Yeah, that's a really good way of putting it.
So you can kind of separate out the yellow flags are it's not so much a structural emergency, but you can turn it into a pain emergency if you don't listen to them. Where the red flags are, it's a structural, life-threatening emergency where it doesn't matter what the person feels about the situation. You know, if you don't do something about it, they could have progressive cancer that metastasizes. They could have, right, a spinal cord injury that makes them paralyzed, right? Like it's very sinister and serious, and we have to be able to, and you err on the side of caution, certainly with those things.
Yeah.
But that's really important to know, again, for anybody. I mean, I just took my CPR and first aid a couple months ago, again, to like re-up that. And just, you know, I think more and more now they're even trying to simplify that for the general population of like, what does a stroke look like early on? So, you know, and, you know, what does it look like? What do you do for somebody if you really don't feel confident in CPR? Well, like, how do we simplify it to give that person the best, you know, way to make it? Well, just forget about the breathing, just do chest compressions, right? Like, it really seems like that's a movement that it's not just about professionals, it's about the general population, because in those situations, it's about saving lives. I think with the yellow flags, it's about just making sure that you don't really put someone into a bad situation because they've already, they're right on the edge of being there, you know?
Mm-hmm. Definitely.
So, but I think that's pretty comprehensive discussion. So we're certainly going to talk about pain more every time we talk about specific movement, right? Because my goal with this podcast is to take, you know, this idea of this framework of the movement continuum, but then really get more specific to talking about the squat, talking about the lunge, talking about specific movements, functional to really high level strength and conditioning, and to really just see this broad spectrum of how we can look at movement. And pain's always going to be part of that. This is the first marker of control that you can kind of look at from an assessment process. So we're also going to discuss, you know, postural control, breath control, impact control within movement. So pain will come up over and over again, especially as we get more specific. And hopefully, a lot of times when we get more specific, the broader concepts make more sense. So, but I think we did a pretty good job touching on a pretty tough subject there.
Yeah, we're getting better.
We're getting better. All right, man. This has been fun. I will see you later in the week.
All right. Sounds good.
All right, later.